Laparoscopic cholecystectomy. Problems associated with anesthetizing a patient for laparoscopic cholecystectomy, caused by pneumoperitoneum. CO2 used as the insufflation gas. Positioning on the table. Reverse Trendelenburg. Surgical procedure itself. Cholecystectomy. These can be discussed in terms of their physiological effects on cardiovascular system, respiratory system. Less important, renal, metabolic, neuroendocrine systems. Effects on the cardiovascular system. Hemodynamic changes due to pneumoperitoneum. Reverse Trendelenburg. Hypercarbia, NGA, cardiac index, venous return. IVC compression. Reverse Trendelenburg. Paradoxical CVP and PCWP. Due to central blood redistribution or intrathoracic pressure. SVR, aortic splanchnic compression, humeral factors, catecholamines, PGs, vasopressin. MAP, ischemia, alterations in supply-demand. Arrhythmias, vagally mediated AV dissociation, nodal rhythm, sinus bradycardia, asystole. Ventricular arrhythmias. High CO2 cardiac failure. Effects on the respiratory system mainly due to pneumoperitoneum and CO2 insufflation. Reverse Trendelenburg attenuates some adverse effects. FRC, diaphragmatic displacement. Cephalad, chest wall dimension. Muscular tone, changes in intrathoracic blood volume. Atelectasis, pulmonary shunting, hypoxemia. Airway pressures. Peak airway pressure 6 cmH2. A risk of barotrauma, pneumothorax. Physiological dead space. Total lung compliance. CO2 absorption, ETCO2 rises by 8-10 mmHg, plateaus after 40 minutes. Respiratory acidosis, with CVS consequences if not corrected. Need 25% in minute volume. Endobronchial intubation. Carina moves upwards during insufflation, may manifest as bronchospasm. Effects on the renal system. Cardiac output, renal blood flow and GFR. Renal vascular resistance, due to raised intra-abdominal pressure. Overall urine output, especially with prolonged procedures. Additional potential problems: acid aspiration, trocar injuries, venous gas embolism, bleeding, burns and explosions. DVT, drowning, ATOTW1. Definition: drowning is defined as respiratory impairment resulting from submersion or immersion in liquid. Outcomes are classified as death. Morbidity: no morbidity. WHO recommends avoiding confusing terms like wet drowning, dry drowning, near drowning, secondary drowning too. Pathophysiology: submersion, breath holding, gasp, reflex inhalation of liquid into airways. Laryngeal spasm initially prevents water aspiration. If prolonged hypoxia occurs, spasm breaks massive aspiration. Small volumes of water, 1-3 ml/kg, disrupts surfactant, impairing alveolar stability. Surfactant washout leads to alveolar collapse, reduced compliance, pulmonary shunting, and hypoxemia. Freshwater aspiration, hypotonic fluid absorbed into bloodstream. Causes: hemodilution, hemolysis, hyperkalemia, rare, clinically important now. Seawater aspiration, hypertonic, draws plasma into alveoli, causes pulmonary edema, intrapulmonary shunting. Bronchospasm may occur in both freshwater and saltwater drowning. Inflammatory mediator release: IL-6, TNF-alpha, pulmonary hypertension and exacerbation of alveolar damage. Negative pressure: pulmonary edema may occur with intense inspiratory efforts against obstruction. Secondary infections possible if contaminated water aspirated. 3. Hypothermia and its role: peripheral cooling, muscle and nerve dysfunction precedes central hypothermia. Hypothermia slows metabolism, reduces oxygen demand, and provides neuroprotection if it precedes hypoxia. Severe hypothermia causes bradycardia, VF risk below 28 degrees Celsius, coagulopathy, metabolic acidosis, difficulty detecting vital signs, no one dead until warm and dead, temperature management, target mild therapeutic hypothermia. 32 to 34 degrees Celsius, if ROSC is achieved and coma persists. Rewarming cautiously guided by hemodynamic status. 4. Fatal volume of water aspiration: 1-3 ml/kg of aspirated fluid. Significant surfactant damage and hypoxia. 11 ml/kg aspiration typically fatal due to severe alveolar collapse and ARDS. 5. Freshwater versus seawater drowning: modern focus is not on type of water but on oxygenation, ventilation, and resuscitation. 6. Pre-hospital management: airway, breathing, circulation, ABC approach. Immediate 5 rescue breaths crucial if unresponsive and not breathing. Early CPR improves neurological outcomes dramatically. Remove the patient supine or in fetal position to reduce risk of circulatory collapse due to loss of hydrostatic support. Avoid Heimlich maneuver, ineffective and may cause aspiration. Deliver high-flow oxygen ASAP. Bag mask ventilation must be gentle, small tidal volumes to prevent ventilator-induced lung injury. Volley. Consider cervical spine precautions if trauma suspected. 7. Hospital definitive care airway and breathing. Administer high-flow oxygen immediately. Apply PEEP via NIV or invasive ventilation to improve oxygenation. Protective lung ventilation strategies. Tidal volume 6 ml/kg. Ideal body weight. Plateau pressure 30 cm H2O. SO2 target 88%, pH 7.2. Intubate early if severe hypoxia or acidosis, impaired consciousness, inadequate respiratory effort. Bronchoscopy may be needed to clear debris or diagnose pneumonia. Surfactant therapy has been used selectively to improve oxygenation. ECMO considered for refractory hypoxemia despite maximal ventilatory support. Cardiovascular support. Hypovolemia common, fluid shifts, diuresis. Fluid resuscitation with warmed crystalloids, e.g., 20 ml/kg bolus. Vasopressors if hypotension persists despite fluids. Treat arrhythmias per standard ALS guidelines. VF, VT, bradycardia, asystole. Other supportive care. Correct electrolytes, hyponatremia especially in children. Manage hypoglycemia and seizures if present. No routine prophylactic antibiotics unless exposure to contaminated water. Tetanus immunization if necessary. Steroids not recommended routinely. 8. Sequelae of drowning. Neurological injury is the most critical long-term determinant. Direct hypoxic ischemic encephalopathy worsened by hypotension, acidosis, seizures. Secondary complications, ARDS, secondary pneumonia, acute kidney injury from rhabdomyolysis, Takotsubo cardiomyopathy, neurogenic myocardial stunning. 9. Prognostic factors. Better prognosis if short submersion time, early rescue, breath started, short time to effective ventilation. Poor prognosis with prolonged submersion, delay in CPR, asystole on ED arrival, fixed dilated pupils, severe metabolic acidosis. Final takeaway: drowning is primarily a hypoxic event complicated by pulmonary injury, hypothermia, and neurological sequelae. Early ventilation, protective mechanical support, correction of hypoxia, acidosis, and careful temperature management are essential for survival and better outcomes. Burns summary definition: injury from heat, chemical, electrical, or radiation exposure. High-risk groups, 5 years and 65 years age. Classification by depth: superficial, partial thickness, superficial, deep, full thickness. By extent, Rule of 9S, Lundan-Broader chart, Palmer method. By cause: thermal, chemical, electrical, radiation. Pathophysiology: systemic response, burn shock, capillary permeability, plasma loss, hypovolemia, hemoconcentration, metabolic acidosis, hyperkalemia, initially hypokalemia, later SIRS-like response. Mods: initial assessment, ED. Airway: suspect inhalation injury with facial burns, soot, stridor. Breathing: 100% oxygen, beware CO poisoning and cyanide inhalation. Circulation: 2 large bore IVs, fluids if 15 to 20% TBSA. Disability: GCS check, anticipate CO intoxication. Exposure: full body inspection, prevent hypothermia. Airway management indicators for intubation: stridor, hoarseness, facial burns, GCS 8. Early intubation, prefer before facial edema progresses. Difficult airway, prepare for emergency cricothyroidotomy. Breathing issues: smoke inhalation, affects upper airway, chemical irritation, bronchospasm. CO poisoning: 100% O2 or hyperbaric oxygen. Cyanide poisoning, treat with O2, sodium nitrite, thiosulfate. Fluid resuscitation indication: 15 to 20% TBSA adults, 10% in children. Parkland formula: 4 milliliters x weight, kg, x% TBSA. Timing: half in first 8 hours, rest over next 16 hours. Fluids: Ringer's lactate. Monitoring: urine output, 0.5 ml/kg HR adults, 1 ml/kg HR kids. Escherotomy indications: circumferential burns with compromised perfusion or ventilation. Procedure: midlateral or medial cuts through eschar, monitor distal perfusion. Wound care: initial, cover burns with cling film or clean cloth. Cleaning: saline or mild antiseptics daily. Topicals: silver sulfadiazine, avoid near eyes, mefenide. Dressings: non-adherent gauze, antimicrobial dressings. Early excision and grafting, reduces infection, hospital stay. Infection control risks, TBSA, 30%, invasive lines, delayed closure. Prevention, hand hygiene, early closure, nutrition. Treatment, no prophylactic antibiotics, culture-based therapy. Electrical burns. Key points, deep tissue injury, rhabdomyolysis, arrhythmias. Management, high-volume fluids, cardiac monitoring, fasciotomy if needed. Chemical burns. First step, copious irrigation. Caution, no neutralizers, risk of exothermic reactions. Special antidotes, e.g., calcium gluconate for hydrofluoric acid. Nutrition state, hypermetabolic within 24-48 HRS. Calories, adults 25-30 kcal/kg plus 40 kcal% TBSA. Proteins, adults 1.5 to 2 g/kg day, more for children. Route, early enteral feeding preferred, parenteral if not feasible. ICU care. Airway, secure tube position, beware edema and extubation. Breathing, protective ventilation. Low tidal volume, high PEEP. Sepsis, high risk, treat based on cultures. ABC score, predicts mortality based on TBSA, age, inhalation injury. Pain management. Background pain, paracetamol, NSAIDs, oral opioids. Procedural pain, IV opioids, ketamine IV Imoral, Entonox. Chronic pain, watch for opioid tolerance. Long-term issues. Physical, contractures, neuropathy, disfigurement. Psychological, PTSD, depression. Early counseling improves recovery, management of the head-injured patient. Definition: head injury equals trauma to the head excluding superficial facial injuries. Includes TBI, subdivided into primary, initial, and secondary, after effects injury. Introduction, head injury, trauma to the head excluding superficial facial injuries. Bimodal distribution, young adults, 15-29 years, and elderly. Causes, road accidents, falls, assault. Severe TBI mortality 40%, only 20% make a good recovery. Classification by GCS, mild, moderate, severe. By mechanism, blunt versus penetrating. Primary versus secondary injury. Primary, direct trauma e.g., contusions, hematomas. Secondary, worsening by hypoxia, hypotension, raised ICP, seizures, hyperthermia etc. Neurophysiology relevant to severe head injury. Goal is to maintain cerebral blood flow and reduce oxygen consumption. Oxygen delivery falls with hypoxia, hypotension, raised ICP, anemia. Oxygen consumption increases with hyperthermia and seizures. Normal CBF equals 50 ml/100 g-min, falls to 25 ml/100 g-min after severe head injury. CPP equals MAP, ICP, target CPP is 50-70 mmHg. ICP, 20 mmHg requires urgent treatment. Monroe-Kelly hypothesis, skull contents fixed, small increases compensated initially, then rapid ICP rise. PaCO2 is a potent regulator of CBF, increased PaCO2 increased CBF increased ICP. PaO2 is less than 8 kPa also increases CBF. Initial assessment, primary survey. Follow ATLS principles, airway with cervical spine immobilization, intubate if airway compromise or GCS8. Breathing, PaO2 is greater than 13 kPa, PaCO2 4.5 -5 kPa. Circulation, MAP 80 mmHg, if no ICP CPP 50-70 mmHg, if ICP monitored fluids. 0.9% NaCl. Avoid dextrose, vasopressors, metaraminal noradrenaline. Disability, neurological assessment to look for disability, due to TBI. Glasgow Coma Scale GCS used for consciousness assessment. Pupil size and reactivity checked. Exposure, full examination, avoid hypothermia. Signs of raised ICP, early headache, vomiting, seizures, papilloedema, focal deficit. Late, decreased GCS, hypertension and bradycardia. Cushing's reflex, abnormal posturing. Investigations and referral, CT head urgently if GCS 13 at any time, 15 after 2 hours, open or depressed skull fracture, signs of basal skull fracture, seizure, focal deficit, 1 vomiting episode, clotting abnormality. Neurosurgical referral for surgically significant findings, persistent GCS8, confusion, 4 hours, deterioration in GCS, seizures, CSF leak, penetrating injury. Initial management, airway intubation indications, loss of airway reflexes, bleeding into airway, GCS8, hypoxia, hypercarbia, spontaneous hyperventilation, irregular respirations, seizures, bilateral mandibular fractures, deteriorating GCS. Modified RSI with thiopentone or propofol plus opioid and succinylcholine or rocuronium. Manual inline stabilization for cervical spine if not cleared. Breathing. Avoid hypoxia and both hypercapnia and hypocapnia. Target PaO2 is greater than 13 kPa, 98 mmHg. Target PaCO2 4.5 to 5.0 kPa, 34-38 mmHg. If raised ICP, moderate hyperventilation to PaCO2 4 kPa, 30 mmHg, can be used temporarily. Circulation. Avoid hypotension. Maintain MAP 80 mmHg if ICP unknown. Target CPP 50-70 mmHg if ICP measured. Use 0.9% NaCl for fluids. Avoid hypotonic fluids like dextrose. Vasopressors, metaraminal or noradrenaline, if needed to maintain MAP. Disability without ICP monitoring. Raised ICP may first present as late signs, hypertension, bradycardia, and dilated pupils. Therapeutic targets, ICP 20 mmHg, CPP 50-70 mmHg, glucose 6-10 mol/L. Temperature 37 degrees Celsius. Treat seizures early, e.g., phenytoin 18 mg/kg. Treat hyperthermia actively. If therapeutic targets, oxygenation, perfusion, are met and sedation is adequate, non-surgical ICP control includes as follows. Management of raised intracranial pressure. Initial measures. Reassess airway, breathing, circulation, sedation, venous drainage. Correct PaO2, PaCO2, temperature abnormalities, osmotherapy. Manadol 0.25 to 0.5 g/kg IV bolus or hypertonic saline 100 ml of 5% NaCl. Both reduce brain edema and ICP, improve cerebral perfusion. Hyperventilation. Moderate hyperventilation targeting PaCO2 4 kPa, 30 mmHg, can be used temporarily. Avoid aggressive hyperventilation. PaCO2 is less than 3.5 kPa. Advanced measures. Neuro-ICU. Therapeutic hypothermia. Cooling to 34 degrees Celsius, with neuromuscular blockade to prevent shivering. Thiopentone coma. 3-5 mg/kg bolus, then 3-5 mg/kg HR infusion with EEG burst suppression monitoring. Decompressive craniectomy in refractory cases. Conclusion. Severe TBI requires rapid systematic management to prevent secondary brain injury. Maintain oxygenation, perfusion, normoglycemia, and normothermia. Monitor for and aggressively manage raised ICP. Tiers of management of head injury. Primary tier. Primary survey and immediate life threats addressed, ATLS. Secondary tier. Neurological assessment, CT head, neurosurgical referral if needed. Tertiary tier. Definitive management, surgical decompression, ICP monitoring, ICU care. Prevention tier. Prevent secondary insults, avoid hypoxia, hypotension, hypercarbia, hypoglycemia, hyperthermia, seizures. Monroe-Kelly Doctrine. Summary. The Monroe-Kelly Doctrine states that the skull is a fixed, rigid structure containing brain tissue, 85%, cerebrospinal fluid, 10%, and blood, 5%. Since the total volume inside the skull cannot change, an increase in any one component must be balanced by a decrease in another to maintain normal intracranial pressure. ICP. Compensation occurs in stages. 1. Venous blood reduction. 2. CSF displacement or absorption. 3. Arterial blood reduction, least effective if these compensatory mechanisms fail. ICP rises, which can lead to brain damage or herniation. Positioning and concerns. Positional injuries. 1. Supine position. Most common surgical position. Ventilation, FRCVQ mismatch risk, especially in elderly, obese, pregnant. Use PEEP to counter. Pregnancy, risk of aortocaval compression post 16-20 weeks. Prevent by tilting uterus wedge under right hip. Complications, pressure sores, occiput, sacrum, heels. Ulnar nerve, risk near medial epicondyle supinate forearm, avoid pronation extension. Brachial plexus, avoid abduction, 90 degrees, head should be neutral or turned toward abducted arm. 2. Lithotomy position used in gynae and urology surgeries. Hemodynamics, venous return. Risk of pulmonary edema, sudden leg lowering. Preload hypotension. Complications, nerve injuries, sciatic, common peroneal fibular head, saphenous medial tibial condyle. Risk of compartment syndrome in long cases, 4HRS. DVT risk, use compression devices. Hands by the side, risk of crush injury during table movement, 3. Lateral position used in thoracic, hip, shoulder surgeries. Ventilation, perfusion greatest independent lung, ventilation and non-dependent VQ mismatch. BP cuff on dependent arm may give false readings due to compression. Complications, radial nerve, upper arm, and common peroneal, lower leg injuries. Use axillary roll caudad to axilla to avoid brachial plexus injury. Ensure eyes are protected, ears not folded, and head neutral. 4. Prone position used for neurosurgery, spine, Achilles repair. Ventilation, may improve due to FRC unless abdomen compressed. Hemodynamics, preload, 55 compliance cardiac output. Ensure abdomen is free to avoid IVC pressure and surgical bleeding. Complications, brachial plexus injury if arms abducted, 90 degrees. Eye injury and POVL post-op visual loss prevent with foam headrest. Avoid pressure on eyes. Pressure sores, face, breasts, genitals, bony prominences. Resuscitation and access difficult in this position. 5. Sitting beach chair used in shoulder and posterior fossa surgeries. Hemodynamics, BP due to impaired baroreflexes, risk of cerebral hypoperfusion. Keep map, 70 mmHg, at tragus level. Complications, cerebral ischemia, especially in hypotensive or hypovolemic states. Venous air embolism, V, mild, at CO2. Severe, arrhythmias, RV failure, arrest. Manage. 100% O2, fluids, vasopressors, alert surgeon, left lat. Trendelenburg. Avoid neck flexion, risk of quadriplegia. 6. Trendelenburg head down tilt 15 degrees. Ventilation, FRC, risk of atelectasis, barotrauma. Airway, may migrate, check for endobronchial placement. Complications, intracranial and intraocular pressure. Facial laryngeal edema, do cuff leak test before extubation. Risk of brachial plexus injury if arms not secured properly. 7. Reverse Trendelenburg head up tilt. Ventilation, FRC and lung compliance, adjust tidal volume cautiously. Risk, hypotension and cerebral hypoperfusion due to gravity. Adjust map readings accordingly. Elderly patient and anesthesia, geriatrics anesthesia, general points, elderly equals, 65 years, perioperative risk due to physiological and cognitive reserve comorbidities and frailty, aging causes progressive functional decline across all systems, cardiovascular CVS, theme, disease burden, compliance, fluid sensitivity, structural changes. Myocardial fibrosis, ventricular thickening, compliance, arterial stiffness, systolic HTN, pulse pressure, functional decline, CO with exercise 71% from 5th decade, common AF, preload, loss of atrial kick. Autonomic response, exaggerated hypotension with anesthesia, capillary permeability, risk of pulmonary edema, thirst sensation, risk of dehydration, respiratory system, theme, compliance, dead space. Ventilatory response, ventilatory changes, response to hypoxia and hypercapnia, ventilatory reserve, O2 consumption and CO2 production by 10 to 15%, apnea tolerance, compliance and dead space, pulmonary compliance. Chest wall compliance, alveolar dead space, closing volume, FRC, venous admixture, airway protection, airway reflexes, aspiration, risky edentulous patients, difficult mask seal, renal, theme. Renal mass function, fluid and drug sensitivity, GFR 30% by 8th decade, glomeruli creatinine clearance, serum creatinine may remain normal. Tubular dysfunction, ADH and aldosterone sensitivity, risk of hypovolemia and fluid overload, renal drug clearance, dose adjustment required, risk of electrolyte imbalances, hepatic, theme. Mass and flow, prolonged drug effects, hepatic mass and blood flow, up to 40% by 9th decade, clearance, duration of hepatically metabolized drugs affects opioids, propofol, benzodiazepines, NMDAs, neurological, theme, reserve. Confusion risk, sensitivity to opioids, brain size and neuronal mass, distinguish dementia versus reversible confusion, hypoxia, sepsis, pain, metabolic, sensitivity to opioids, sedatives, consciousness, respiratory depression, risk of POD, post-op delirium, POND, post-op neurocognitive disorder lasting 30 to 12 mo, contributing factors, pain, infection, malnutrition, withdrawal, electrolyte imbalance, POND more likely after major emergency cardiac surgery. Hematology and immune system. Theme: clotting, immunity, hypercoagulability and DVT risk, anemia, marrow response, immunity, marrow, spleen, thymus, infection risk, endocrine. Theme: glucose issues, common glucose tolerance risk of DM, stress response, hyperglycemia risk perioperatively, thermoregulation. Theme: hypothermia risk, impaired thermoregulation, hypothermia risk, shivering, O2 consumption, vasoconstriction, cardiac workload, pharmacology. Theme: altered distribution, metabolism, sensitivity, TBW, fat. Volume of distribution for water-soluble drugs, dose needed, volume for lipid-soluble drugs, prolonged clearance, CO drug distribution, volume, arm, brain circulation, time, delayed onset of induction drugs, albumin-free drug, e.g., opioids, benzos, MAC, 6% decade, due to neuronal mass, NSAIDs, GI bleed, OCI risk, especially with ACE inhibitors, anesthesia for elderly patients. Key principles: perioperative mortality increases with age, ASA status, and surgical urgency. Multidisciplinary assessment, optimal anesthetic choice, and meticulous care reduce complications. The technique is less important than the way it is delivered, tailored to physiological condition. 1. Preoperative assessment and management checklist. 1. System review. 2. Daycare feasibility. 3. CVS status, baseline activity level. 4. Cognition, GCS. 5. Smoking and alcohol history. 6. Comorbidities must optimize. 7. Continue regular meds, medication review. Continue most medications. Omit oral hypoglycemics, avoid opioids, benzodiazepines, pethidine, give antiemetics. Continue Greek letter beta blockers. 2. Special considerations: A systematic review essential. Additional preoperative considerations: Day surgery is appropriate for fit patients undergoing minor surgery. It reduces disorientation from hospital admission. Level of physical activity is a good indicator of cardiorespiratory fitness, though may be limited by joint disease. Mental state should be evaluated using the mini mental state examination to differentiate dementia from acute confusion. Consider pre-optimization of medical conditions. This may involve delaying surgery for stabilization, especially in non-elective cases. Delayed mobilization post-op, e.g., in lower limb fractures, increases risks, pressure sores, DVT, pneumonia. Oral hypoglycemics should be withheld. Other medications continued till surgery. Smoking cessation is ideal but not mandatory pre-op. Nicotine patches may help. B. Frailty defined as physiological reserve to handle surgical stress. Associated with complications, hospital stay, death. Use tools like Rockwood or Edmonton frailty scales. C. Nutrition. Older patients often have unrecognized malnutrition. Consider nutritional supplements pre-op to reduce complications. 3. Perioperative management. Regional anesthesia may reduce DVT, infection, bleeding, cognitive dysfunction. MAC should be age-adjusted. Use TIVA with TCI where applicable. Ensure careful BP monitoring. Watch for GA, spinal-induced hypotension. Consider invasive BP, depth monitoring. Use fluid warmers to avoid hypothermia. Avoid long hypotensive periods, pressure sores. Use soft padding for pressure points. 4. Postoperative management checklist. 1. HDU if needed. 2. Vitals plus labs. 3. HB target. 9-10 GDL. 4. Good analgesia. 5. Treat reversible causes of delirium. 6. Early mobilization notes. Monitor fluid balance, electrolytes. Consider delirium causes, pain, hypoxia, drug effects, etc. Prefer paracetamol and regional techniques over opioids. Enable early rehab and communication to improve outcomes, anesthesia for carotid endarterectomy. ATOTW tutorial. Background C is performed to prevent embolic strokes by removing atherosclerotic plaque from the carotid artery. High-risk procedure with a 2 to 5% risk of major stroke or death. Evidence: NASCET, ECST, ACST trials, support C in symptomatic patients with high-grade stenosis, especially within 2 to 4 weeks of a TIA or stroke. Comorbidities like hypertension, diabetes, and COPD affect outcomes. Shunting in cerebral ischemia. Carotid cross-clamping temporarily stops flow through the carotid artery during surgery. If collateral circulation via circle of Willis is inadequate, this can lead to cerebral ischemia. Shunting involves inserting a bypass tube to maintain cerebral perfusion during clamping. Shunts, e.g., Javid or Pruitt in Ahara, carry risks: embolism, dissection. Awake patients allow direct monitoring of brain function to detect ischemia early and guide shunt use. Monitoring cerebral perfusion gold standard. Awake neurological monitoring grip strength, speech, cognition. Under GA, options include stump pressure, transcranial Doppler, EEG, near-infrared spectroscopy. None are completely reliable. Local versus general anesthesia. Local anesthesia allows direct neuromonitoring. Reduced shunt and complication rates. Preserved autoregulation. GA advantages: controlled ventilation, CO2, better surgical conditions, avoids emergency airway management. Gala trial ongoing at time of writing, aims to compare outcomes in GA versus LA. Regional anesthetic techniques. 1. Cervical epidural, rarely used, high complication rate, hypotension, bradycardia, respiratory failure. Dural puncture risk, 0.5%. 2. Superficial cervical plexus block, inject LA subcutaneously along SCM posterior border, Erb's point. Modified version injects deeper under fascia, intermediate block, with better spread. 3. Deep cervical plexus block, DCPB, single injection at C4 targeting nerve roots. Risk: phrenic nerve block, RLN involvement, stellate ganglion. Contraindicated in patients with poor respiratory reserve. Often requires supplementary infiltration due to incomplete block. 4. Mandibular trigeminal supplementation, needed in high carotid bifurcation cases, jaw discomfort. May use jawline infiltration or inferior alveolar block. 5. Local infiltration by surgeon, can be used alone, often as supplement. Preoperative assessment: assess cardiac and respiratory comorbidities, phrenic nerve block risk. Identify contraindications to LA, patient refusal, movement disorders. Continue all medications except diuretics. Risk of dehydration, urinary retention. Maintain aspirin statins, consider clopidogrel risks. Avoid sedatives to preserve neurological assessment. Tight glucose control. Assess for existing neurological deficits. Document carefully. ECG, bloods, cross-match, bladder emptied pre-op, perioperative management. Minimum monitoring, ECG, SPO2, invasive BP contralateral arm, 2 IV lines, fluids plus infusions. Blood pressure control critical, vasopressors, metaraminol, phenylephrine. Antihypertensives, labetalol, GDN, management under local anesthesia. Use Tivicidation propofol during prep, off before clamping. Monitor grip strength, speech, awareness. Heparin before cross-clamp 3000 to 5000 IU. Avoid protamine. If deficit occurs, check airway and BP, give O2. Insert shunt if no improvement. If still unstable, convert to GA with propofol plus LMA. Management under general anesthesia. Balanced GA with invasive BP monitoring. Airway, or Prozeal LMA. Control PaCO2 with ventilation. Remifentanil for smooth emergence and fast neuroassessment. Superficial plexus block helps reduce intra-op opioids and post-op pain. Postoperative care: high dependency monitoring for 4 to 6 hours post-op. Watch for neurological deficits, urgent duplex scan or re-exploration. Hypertension, control aggressively, e.g., labetalol. Hyperperfusion syndrome, headache, seizures, cerebral hemorrhage, due to loss of autoregulation after stenosis relief. Wound hematoma, can cause airway obstruction. Emergency management, remove sutures, re-explore under LA. Summary: C. Anesthesia is complex and outcome dependent on surgical and anesthetic expertise. LA allows direct neuromonitoring but is not always practical. GA is commonly used with good results. Meticulous monitoring, blood pressure control, and post-op care are crucial. Perioperative management of patients with pulmonary hypertension and right ventricular dysfunction. Key points: pH equals MPAP 20 mmHg. Perioperative focus: preserve right ventricular RV function. RV compromised by perfusion, due to SVR, or afterload, due to PVR. Avoid hypoxia, hypercarbia, acidosis, and hypothermia to prevent PVR spikes. Regional anesthesia often preferred to protect SVR and PVR. Introduction, pH classification by ESCers. 1. Pulmonary arterial disease. 2. Left heart disease. 3. Lung disease. Hypoxia. 4. Pulmonary artery obstruction. 5. Multifactorial epidemiology, more common in women, typically diagnosed in 50s. Causes differ globally, infections in LMICs versus COPD, LVF and HEECs. Often delayed diagnosis due to nonspecific symptoms. Right ventricular physiology and pathophysiology. RV is thin-walled, less muscular, low-pressure system. Perfused mainly by the RCA throughout the cardiac cycle, not just diastole. RV perfusion depends on MAP, not just DBP. RV vulnerable to ischemia if MAP drops or PVR rises. Chronic PHRV hypertrophy, reduced compliance, poor tolerance to acute pressure changes, interventricular septal shift, biventricular failure, pulmonary vascular resistance PVR, influenced by passive factors, gravity, posture, lung volume. Active factors, PVR, hypoxia, hypercapnia, acidosis, histamine, serotonin, PVR, oxygen, hypocapnia, alkalosis, nitric oxide, prostacyclin, preoperative assessment, history. 4 categories of symptoms. 1. CO, dyspnea, fatigue. 2. RV failure, syncope, chest pain, fluid retention. 3. Intrathoracic mass effect, hoarseness, laryngeal nerve compression. 4. Cause-specific, OSA, COPD, VTE, HIV, CTDs, drugs examination, JVP, hepatomegaly, ascites, edema, TR murmur, loud P2. Investigations echo, per British guidelines, RV size function, Pennsylvania size, septal flattening. ECG, RAD, RBBB, RV strain CXR, PANRA enlargement. Labs, BNP, renal function. PFTs, especially for class 3/5 PH right heart catheterization, gold standard, MPAP, PVR, wedge pressure. CPET, risk stratification, peak VO2, VEV-CO2 ratio, chronic pH management, managed in tertiary centers UK, MPAP 25 mmHg. Main drug classes. 1. PDE5 inhibitors e.g., sildenafil. 2. Guanylate cyclase stimulators e.g., riociguat. 3. Prostacyclin receptor agonists e.g., selexipag. 4. Endothelin receptor antagonists e.g., bosentan, diuretics, oxygen, anticoagulants as needed. Continue all therapies perioperatively, convert to IV inhaled if needed. Intraoperative care, pre-op decision-making, specialist consult. Essential risk versus benefit of surgery must be evaluated carefully. Goals. 1. Maintain RV perfusion, avoid hypotension, support SVR with vasopressors, noradrenaline, vasopressin. 2. Avoid PVR, prevent hypoxia, hypercarbia, acidosis, lung over-underinflation, hypothermia, pain. Pulmonary vasodilators inhaled. No. Prostacyclin analogs, iloprist, epoprostenol. Used in specialized centers. Inotropes levosimendan, milrinone, support RV contractility and PVR. Anesthesia techniques, regional anesthesia preferred when feasible, avoids myocardial depression. Good opioid-sparing effect. Sedation should be minimized. Anticoagulation status must be checked. Central neuraxial block can cause rapid SVR and HRRV under perfusion collapse. Use cautiously with hemodynamic goals in mind. General anesthesia required in many cases. Safe with careful management. Avoid nitrous oxide, PVR. Control ventilation to maintain normocapnia and oxygenation. Agents, use standard IV volatile agents within safe doses. Monitoring standard plus invasive monitoring A-line, CVP, PAC, etc. Targets, SBP 90 mmHg, MAP 65 mmHg, PVR SVR ratio, 0.4, cardiac index 2.2, RAP, lowest to maintain MAP, 65. Avoid myocardial depression and rhythm abnormalities. Postoperative care, high dependency unit needed. Maintain SVR, avoid PVR spikes. Opioid-sparing analgesia, paracetamol, NSAIDs, regional blocks. Continue pH medications without interruption. Watch for arrhythmias, often supraventricular. Aim to maintain sinus rhythm. Use cardioverter or antiarrhythmics as needed. Minimal negative inotropy preferred. Pulmonary hypertensive crisis, PHC, acute rise in PVR overwhelms RV. Mortality, 50%. CAN LV preload, CO, coronary perfusion, cardiogenic shock. Causes, positioning, pneumoperitoneum, drugs, etc. Management. 1. Supportive, oxygen, fluids, judicious, ventilatory support, temperature control. 2. Pharmacologic, inotropes e.g., milrinone, vasopressors e.g., noradrenaline, pulmonary vasodilators e.g., no, prostacyclin, thalassemia. Normal hemoglobin HbA. 2 alpha plus 2 beta chains. Minor components, HbF and HbA2. Definition: hereditary hemoglobinopathy caused by partial or complete deficiency in the synthesis of one or more globin chains, leading to Ineffective erythropoiesis, chronic hemolytic anemia, microcytosis and hypochromia. Classification by globin chain affected. Greek letter alpha thalassemia or Greek letter beta thalassemia by clinical severity. Thalassemia minor, thalassemia intermedia, thalassemia major. HB Bart's disease, Hydrops fetalis, 1. Thalassemia minor, trait, genetics, heterozygous mutation in one Greek letter alpha or Greek letter beta gene. Pathophysiology, 50% reduction in globin chain synthesis, slight imbalance in Greek letter alpha, Greek letter beta chain ratio. Mild ineffective erythropoiesis. Clinical features, often asymptomatic mild anemia, HB10-11 GDL, microcytosis, hypochromia. No transfusions required. Diagnosis: peripheral smear, target cells. HB electrophoresis, Greek letter beta thal trait HbA2, 3.5%, Greek letter alpha thal trait may appear. Normal prognosis, benign, genetic counseling is important. 2. Thalassemia intermedia. Genetics, homozygous or compound heterozygous Greek letter beta mutations or Greek letter beta thal with co-inherited Greek letter alpha thal trait. Pathophysiology, moderate imbalance in globin chains, partially preserved HB synthesis, moderate hemolysis and anemia. Clinical features, presence in childhood or adolescence, moderate anemia, HB7-10 GDL, mild bone deformities, splenomegaly. Occasional transfusions during stress or infection. Diagnosis: smear, anisopycalocytosis, electrophoresis, HbF, HbA2. Prognosis, variable, iron overload possible even without frequent transfusions. 3. Thalassemia major, Cooley's anemia. Genetics, homozygous Greek letter beta thalassemia, both Greek letter beta genes defective. Pathophysiology, absent or near absent Greek letter beta globin synthesis. Severe Greek letter alpha, Greek letter beta chain imbalance. Ineffective erythropoiesis, hemolysis. Extramedullary hematopoiesis. Clinical features, presence at 4-6 months of age. Severe anemia. Frontal bossing, maxillary overgrowth, growth retardation. Hepatosplenomegaly. Iron overload from transfusions. Diagnosis: HB electrophoresis, HbF, little or no HbA. Management, regular transfusions, iron chelation therapy, splenectomy if needed. Bone marrow transplant is curative. Prognosis, good with optimal care, poor without treatment. 4. HB Bart's disease, Hydrops fetalis. Genetics, deletion of all 4 Greek letter alpha globin genes. Pathophysiology, no Greek letter alpha chains, only HB Bart's. Greek letter gamma 4, forms HB Bart's, has high oxygen affinity, no tissue oxygen delivery. Severe hypoxia, heart failure in utero. Clinical features, generalized fetal edema. Hydrops, ascites, pleural effusion, usually intrauterine death or stillbirth. Diagnosis, antenatal ultrasound, hydrops, cord blood. HB Bart's on electrophoresis. DNA analysis. Prognosis, usually fatal unless treated with intrauterine transfusions and postnatal BMT. Risk of maternal complications. Mirror syndrome, general pathophysiology. HbO2 carrying erythropoietin excess. Unpaired globin chains precipitate in erythroblasts. Membrane damage. Ineffective erythropoiesis. Hemolysis and circulation. Chronic anemia. Marrow expansion. Bone deformities. Repeated transfusions. Iron overload. Clinical features, multi-system involvement, skeletal, frontal bossing, maxillary overgrowth, osteoporosis. CNS, intellectual disability. CVS, heart failure, pulmonary HTN. Lungs, restrictive disease. Endocrine, hypogonadism, hyperthyroidism. Liver, spleen, hepatosplenomegaly, cirrhosis. Skin, hyperpigmentation, complications. Iron overload. Blood-borne infections. Transfusion reactions. Organ failure. Cardiac, hepatic. Endocrine treatment summary. 1. Regular transfusions. 2. Iron chelation therapy, deferoxamine, deferasirox, deferiprone. 3. HbF modulation, hydroxyurea. 4. Splenectomy indicated for hypersplenism. Delay until 5 years age. Vaccinate meningococcus, pneumococcus, H, influenza. 5. Gene therapy. Hepcidin modulation. 6. Stem cell transplant, curative, anesthesia. Considerations in thalassemia, key concerns: intellectual disability, skeletal deformities, difficult airway, regional anesthesia, pulmonary edema, heart failure, pulmonary hypertension, pathological fractures, careful positioning, thyroid crisis, if hyperthyroid, anemia, hypercoagulability, pre-op workup, full history, physical, systems review. CVS, dyspnea, orthopnea. Murmur 2D echo resp, restrictive pattern PFTs HB optimization, minor, tolerate HB6-7 major uncompensated, target, 10G DL iron profile, HB electrophoresis LFTs, RFTs, electrolytes TFTs, glucose airway and spine exam. Intraoperative management mode, GA or regional, any safe, but regional may be difficult monitoring, ECG, NIBP, SPO2, capnography invasive, arterial line, temperature, Foley's advanced, CO monitoring, T if indicated avoid fluid overload. Triggers for pulmonary HTN use blood conservation, avoid hepatotoxic drugs pad bony areas carefully mechanical DVT prophylaxis awake extubation preferred, post. Op care tailored to surgery and patient condition early mobilization thromboprophylaxis monitor for transfusion-related complications, myotonic dystrophy, Julian Barker, short case. Clinical scenario, a 35-year-old male patient with mild myotonic dystrophy presents for wisdom teeth extraction. Underlying metabolic problem, it is an intrinsic muscle disorder. There is delayed muscle relaxation due to abnormal closure of sodium chloride channels following depolarization, causing repetitive discharge and contraction. Clinical features, head to toe, general. Frontal balding lateral smile muscle wasting especially sternocleidomastoids, shoulders, and quadriceps, gonadal atrophy infertility ptosis cataracts low serum IgG neurological. Bulbar problems slurred speech dysphagia aspiration frequent cause of death, decreased tone and reflexes with muscle wasting foot drop decreased IQ and 40% cardiac, conduction defects, primary heart block, bundle branch block. Widened QRS may require pacing increased QTc and PR interval cardiomyopathy cardiac failure mitral valve prolapse Respiratory muscle fatigue poor cough LRTI restrictive lung defects centrally mediated decreased ventilatory response to CO2 obstructive sleep apnea chronic hypoxemia core pulmonale gastrointestinal constipation delayed gastric emptying endocrine diabetes mellitus hypothyroidism anesthesia related problems 1. Undue sensitivity to anesthetic drugs, opioids barbiturates volatile agents 2. Precipitation of myotonia by anesthetic and surgical interventions diathermy cold monitor and maintain temperature pregnancy noted in literature, e.g., postpartum hemorrhage, shivering high volatile concentrations none. Depolarizing muscle relaxants anticholinesterase drugs potassium containing solutions exercise 3. Cardiovascular and respiratory problems, especially aspiration risk 4. Control of blood sugar, necessary due to diabetes risk 5. Drug interactions, risk with phenytoin, quinine, procainamide 6. Late presentation, often diagnosed late, 2nd-4th decade, may be undiagnosed at anesthetic assessment. Note, no proven association with malignant hyperthermia anesthetic techniques preoperative, ECG 24-hour if indicated. Blood count, urea, electrolytes especially K, blood sugar pulmonary function tests arterial blood gases chest x-ray pre-medication, avoid respiratory depressants antacids are advisable invasive monitoring. Consider arterial line CVPPAFC if arrhythmia or cardiomyopathy present. Note, for PA catheter, general rule for exam purposes 1. If disease severe enough to indicate its need 2. If expertise available. Temperature, must be monitored and maintained warming mattresses and warmed IV fluids induction and maintenance. Propofol is safe. But use with caution intubation is critical to prevent aspiration high concentrations of volatiles may worsen shivering and myotonia regional anesthesia. Preferable if possible avoids triggering myotonia nerve blocks won't stop myotonic reflex local infiltration into muscle can help suppress the reflex muscle relaxants, avoid if possible if required. Use atracurium in small doses. Neuromuscular monitoring is essential postoperative. Consider HDUIQ care. Early feeding should be avoided due to aspiration risk. Airway blocks in awake fiber optic intubation. What are the indications for performing an awake fiber optic intubation? Suspected or known difficult intubation full stomach with anticipated difficult intubation cervical spine injury anticipated difficult mask ventilation e.g., morbid obesity contraindications. Patient refusal inability to cooperate bleeding upper airway allergy to local anesthetics upper airway tumor with stridor angioalagogues, glycopyrronium 4-8 mcg kgim or IV hyoscine 0.2 mg im atropine 0.3 to 0.6 mg im. Airway nerve supply and block techniques 1. Nose innervation, sphenopalatine ganglion anterior ethmoidal nerve block, 4% cocaine or lidocaine pledgets nebulized lidocaine spray, 2. Oropharynx innervation, glossopharyngeal nerve CN9, supplies posterior 1/3 tongue, tonsils, soft palate, pharynx topical anesthesia. 10% lidocaine spray, 4% lidocaine gargles, benzocaine lozenges, glossopharyngeal nerve block techniques, anterior, lingual, displace tongue medially, inject 2 ml La at posterior tonsillar pillar, posterior pharyngeal. Insert needle behind tonsillar pillar, 1 cm depth, inject 3 ml La external deep cervical, inject behind styloid process, risky close to ICA and IJV, 3. Larynx above vocal cords innervation, internal branch of superior laryngeal nerve SLN supplies base of tongue, epiglottis, aryepiglottic folds SLN block techniques, external, identify hyoid bone. Walk off lower border, pierce thyrohyoid membrane, inject 2-3 ml of 2% lidocaine bilaterally internal, place lidocaine soaked pledgets in piriform fossa using forceps. 4. Larynx below vocal cords innervation, recurrent laryngeal nerve, branch of CNX, block, cricothyroid puncture, translaryngeal block, identify cricothyroid membrane, insert needle attached to saline. Filled syringe, aspirate air to confirm placement, inject 2-3 ml of 2% lidocaine, patient will cough, spreads La. Bronchopleural fistula. Bronchopleural fistula BPF is a pathological communication between the bronchial tree and the pleural space, most commonly seen post-pneumonectomy or in the setting of necrotizing infections. Causes: postoperative complication, especially pneumonectomy, BPF incidence 1 to 4%, rupture of a lung abscess, tuberculosis, necrotizing pneumonia, especially anaerobic or gram-negative organisms, bronchogenic carcinoma, trauma. Penetrating or barotrauma, iatrogenic causes e.g., lung biopsy, clinical features, persistent air leak through chest drain, respiratory distress, sudden expectoration of fluid, if communication with pleural cavity, pneumothorax, subcutaneous emphysema, sepsis, pyrexia, persistent or recurrent empyema, diagnosis, clinical suspicion in the post-op setting, chest X-ray or CT scan may reveal air fluid levels. Shifting mediastinum bronchoscopy can localize the fistula. Persistent bubbling in underwater seal drainage is a classic clue. Anesthetic implications. Preoperative. Optimize respiratory status. Antibiotics. Chest physiotherapy. Bronchoscopy to localize and size the fistula. Discuss surgical plan, whether thoracoplasty, open drainage, or repair. Intraoperative goals. Prevent contamination of the healthy lung. Absolute priority. Use of double lumen tube DLT or bronchial blocker to isolate the affected lung. Avoid positive pressure ventilation until the lung is isolated. If possible, avoidance of nitrous oxide can expand pleural space and worsen pneumothorax. Maintain adequate oxygenation without worsening air leak. Preparedness for sudden desaturation or tension. Pneumothorax postoperative may need ICU care with low pressure ventilation. Drainage of infected collections. Chest physiotherapy, bronchodilators, nutritional and sepsis support. Viva tips highlight the need for lung isolation early. Emphasize prevention of soiling of the contralateral lung. Understand the risks of mechanical ventilation and barotrauma. Know when to use awake intubation or delay induction until DLT is in place. Tracheal resection. Summary indications. 1. Tracheal stenosis due to prolonged intubation, most common. 2. Tracheal tumor, e.g., adenoid cystic carcinoma, squamous cell carcinoma. 3. Tracheal trauma, often post-intubation. 4. Congenital anomalies. 5. Vascular lesions. 6. Tracheomalacia, surgical options. 1. Sequential resection with primary anastomosis, 80% cases. 2. Segmental resection with prosthetic reconstruction, 10%. 3. Placement of T-tube or stent. Diagnosis: history, dyspnea, respiratory difficulty. Examination: investigations, CT scan, to assess length and level of lesion. Rigid bronchoscopy, definitive diagnostic tool. Methods of securing airway. 1. Standard orotracheal intubation. 2. Small ET insertion into open trachea or bronchus distal to resection site. 3. High-frequency jet ventilation, HFJV. 4. High-flow positive pressure ventilation. 5. Cardiopulmonary bypass, CPB, anesthesia considerations. Good communication with surgical team. Surgeon must be present at induction. Rigid bronchoscope must be immediately available. Preoxygenation with 100% O2 during induction. Avoid collapse. Congenital stenosis, intrathoracic collapse, acquired stenosis, extrathoracic collapse. Bronchoscopy guidelines not to be done alone, and the OT surgeon and anesthetist must be present in case of airway loss. Rigid bronchoscopy preferred. Can bypass obstruction, provides a ventilating pathway even in complete obstruction. Monitoring 1. Standard ASA monitors 2. Arterial line 3. Central venous catheter, especially if CPB is considered. 4. Urine output 5. Temperature. Surgical techniques. First technique, standard, 1. Rigid bronchoscopy. Tracheal dilation 2. ET passed through stenotic segment 3. Proximal ET withdrawn 1. Stenosis is bypassed 4. Diseased trachea resected 5. New sterile ET inserted into distal open trachea 6. Ventilation via sterile circuit through this new ET 7. After anastomosis, sterile ET removed and original ET passed across the anastomotic site. Second technique, low tracheal lesion, 1. If lesion is low, thoracotomy is done for better exposure. 2. Sterile ET passed distal to resection site for ventilation. 3. Once posterior anastomosis is done, rest of steps same as first technique. Third technique, jet ventilation. 1. Small bore catheter or ET inserted through stenosis. 2. Ventilation via intermittent high-flow fresh gas HFJV, post-tracheal resection care. 1. Neck positioning. Maintain neck flexion for several days post-op. Reduces tension on anastomosis. Stay sutures, Guardian sutures, are placed. 2. ET replacement. Replace ET with LMA for bronchoscopy if needed. 3. Tube placement. Tube tip should lie 3-4 cm above vocal cords. 4. Indications for reintubation. Tracheostomy, suspected glottic edema, need for prolonged ventilation. 5. Tracheostomy, if required, should be made distal to the anastomotic site. Wheat pill poisoning. Viva summary. Clinical scenario: a patient is shifted to ICU from the medical ER in a state of shock, requiring double inotropic support. ECG shows PVCs. History reveals nausea, vomiting, epigastric pain, characteristic garlic odor on breath. 1. What is a wheat pill? Constituent, aluminum phosphide, ALP, commonly used as a fumigant pesticide. Fatal dose, 150-500 mg. 2. What is the toxic metabolite? Phosphine gas, highly toxic, released on contact with moisture. Minor byproducts, ammonia, CO2. 3. Mechanism of action: phosphine gas binds cytochrome oxidase, inhibits cellular respiration by disrupting oxidative phosphorylation, alters valency of the heme group in cytochrome systems, leads to profound mitochondrial dysfunction and cellular hypoxia. 4. Clinical features: gastrointestinal, GIT, thirst, nausea, vomiting, burning, epigastric pain, abdominal cramps, cardiovascular CVS, hypotension, tachycardia, arrhythmias e.g., PVCs. Myocarditis, congestive cardiac failure, respiratory, dyspnea, crackles, pulmonary edema, ARDS, chest tightness, hepatic jaundice, tender hepatomegaly, elevated transaminases, renal, oliguria, proteinuria, hematuria, central nervous system, anxiety, apprehension, restlessness, dizziness, ataxic gait, metabolic acidosis, hypomagnesemia. Death usually occurs due to refractory shock, myocarditis, multi-organ failure. 5. Management: decontamination, gastric lavage with edible vegetable oil. Rationale: oil binds and traps phosphine gas, limiting absorption. Supportive ICU care, continuous cardiac monitoring, risk of arrhythmias. Calcium gluconate and sodium bicarbonate for arrhythmias and acidosis. Amiodarone for arrhythmia control. Early hemodialysis may help if the patient survives initial hours. No specific antidote available. Key prognostic indicators: early arrhythmias and hemodynamic instability. Poor prognosis. Survival beyond initial 24 hours equals better outcomes with supportive care. Salicylate poisoning, aspirin toxicity. 1. Source and context: salicylates, acetyl salicylic acid, are found in aspirin tablets, adult and pediatric, oil of wintergreen, methyl salicylate, highly concentrated bismuth subsalicylate, Pepto-Bismol, topical creams e.g., sports bums. Routes of exposure: oral, transdermal, inhalation. Toxic dose: 150 mg/kg, mild, 300 mg/kg, severe, 7.5 grams of aspirin. Notable threshold for adults. Chronic toxicity seen at lower levels in the elderly. 2. Mechanism of toxicity: multifactorial and dose-dependent. Uncouples oxidative phosphorylation, heat generation. Lactic acidosis stimulates respiratory center. Primary respiratory alkalosis progresses to high anion gap. Metabolic acidosis from lactate ketoside salicylate, a weak acid, inhibits Krebs cycle, glycolysis, glucose transport. CNS hypoglycemia despite normal serum glucose. 3. Clinical features: early signs, tinnitus classic hallmark, nausea, vomiting, diaphoresis, tachypnea due to early respiratory alkalosis moderate to severe, hyperthermia, confusion, agitation, hallucinations, dehydration, hypoglycemia, especially CNS, metabolic acidosis, late severe, seizures, coma, noncardiogenic pulmonary edema, arrhythmias, renal failure. 4. Diagnosis: arterial blood gases, early, respiratory alkalosis, late, mixed respiratory alkalosis plus high anion gap, metabolic acidosis, salicylate levels, 300 mgl equals serious toxicity, 500 mgl equals severe toxicity. Levels may peak 6 hours post ingestion, delayed with enteric-coated tablets, or in mol-L, 3.1 mol-L, observe and repeat levels, 3.6 mol-L, no renal failure, start bicarbonate therapy, 5.1 mol-L plus renal failure or severe acidosis, indication for hemodialysis. Other tests. Serum electrolytes: calculate anion gap, blood glucose, CNS signs may be present despite normal serum levels, creatinine, LFTs, urine pH monitoring for alkalinization, ECG, QT prolongation, arrhythmias, rare. 5. Management: A. Initial stabilization, ABCD approach, airway, breathing, circulation, disability, secure airway if GCS is low or seizures present, frequent monitoring, vitals, acid base, glucose, IV fluids for dehydration. B. Decontamination. Activated charcoal 1 gkg, if within 4 hours of ingestion, extended window for delayed release, enteric formulations, see enhance elimination. 1. Urinary alkalinization cornerstone, IV sodium bicarbonate to maintain urine pH 7.5 to 8.0, alkaline urine traps, salicylate in ionized form, enhanced renal excretion, correct hypokalemia to ensure effective alkalinization. 2. Hemodialysis indications: salicylate, 100 mg/dl, acute, or 60-80 mg/dl, chronic. 5.1 mol-L with renal failure or severe acidosis, altered mental status or seizures, pulmonary edema, refractory acidosis, electrolyte imbalance, renal dysfunction. D. Supportive care, glucose, even if serum levels are normal. For CNS depression, cooling; for hyperthermia, benzodiazepines; for seizures, avoid phenytoin. 6. Prognosis: good with early recognition, alkalinization, and dialysis; poor prognosis associated with delayed treatment, elderly with chronic toxicity, severe metabolic acidosis, CNS dysfunction, or pulmonary edema. Alcohol poisoning: ethanol